Welcome to Workflow Redesign, how to move from paper to paperless. This is the second in a series of courses designed to assist you in the selection, implementation, and management of an electronic health record system for your community health center. In this course, you will learn how to evaluate your current workflow so that you can identify inefficiencies and then build a streamlined process into your EHR. You'll also learn how to use your workflow study as a return on investment strategy, and how to migrate your center from paper to a nearly paperless health center. Let's take a look at how one center is analyzing their workflow.
Renewing a prescription has got to be one of the most inefficient things we do here. I mean, we knew it was a problem, but look at this. 14 steps it takes us to renew a prescription, and 6 places where the paper record gets moved from one location to another.
That means 6 places where the record could get lost. One of our clerk's jobs is to try to remember who saw the patient last. I start by looking at the schedule and then viewing the appointment details, and then I go to that physician.
With the new e-prescribing reimbursements, we've got to get this one right. We found 5 steps that slow us down. We should take this map with us during training so that we can compare what we used to do with our new workflow in the EHR. When we get together again, we'll map out lab orders and how we post results.
I'm really concerned about getting the lab results directly into the record with an alert to let us know it's there.
Whichever software we choose, I would feel more comfortable if they already had experience working with our lab contractor.
Until we went through these workflow exercises, I had no idea how many processes we put in place over the last 10 years that were simply inefficient. As I look back, we designed each process to correct a quality improvement initiative. We realized that there were so many paper workflows that our staff was getting confused. Just in our prescription management exercise, I couldn't believe how many administrative tasks and double, even triple entry we impose on the staff to prevent medical errors. Although we need processes in place to protect our patients, this is a great opportunity to streamline them. At first, I was convinced the EHR would take more time processing prescriptions. I'm quick at writing a prescription. It might not be legible, but my nurses have learned to read my writing. At least that's what I thought. Then I found out how many calls we received from the pharmacy just to verify my handwriting. It's old stuff now. See this? Here's a message from the nurse. In 3 clicks, I can open the nurse's note, click here to open the patient record, review the medication and allergy histories. Then I respond with instructions to the nurse along with my digital signature. Click, click, done. You like that? I love it.
Prescription management is a great workflow to begin with because the process of writing and renewing a prescription often affects every department in your clinic. In 2006, pharmacies made hundreds of millions of calls to healthcare providers just to verify handwriting on a prescription. Understanding how you move health information in a paper environment will have the greatest impact on how smoothly you transition into an electronic environment. Once you know how you process information on paper, you can transfer that knowledge into the EHR. Use the transition as an excuse to build new efficiencies into your clinic. There's no better time to put inefficiencies and duplicate paperwork to rest than right now. Before moving on to examine other workflows, it may help to step back just a moment and take a look at the definition of a workflow. You've been managing workflow all your life. Let's start with something simple, such as doing the laundry as an example of a workflow process. First, you gather the dirty clothes. Next, you sort them into piles of whites, colors, and darks. Then you place each pile of clothes one at a time into the washing machine. Sounds simple enough because it has become a routine for you. Well, for most of you. But everyone in the early learning stages experiences a few workflow breakdowns. Perhaps you added bleach instead of detergent to the color pile, or you put a red t-shirt into the whites pile. When these incidents occur, you make a note to self, no more reds in the white pile, and redesign your workflow. Inefficient paper workflows in the healthcare center and in that community are very costly as well, but they can also be deadly. Process redesign was the core message of the pivotal report To Err is Human, Building a Safer Healthcare System. It was published by the Institute of Medicine. In that 1999 report, the authors identified medical errors as a workflow process problem. They defined medical errors as the failure of a planned action to be completed as intended or the use of a wrong plan to achieve an aim. In the decade since the IOM published this report, researchers from the Centers for Medicare and Medicaid Services, or CMS, and quality improvement organizations and medical and health information associations have studied the most inefficient workflows in hospital and ambulatory care to see how we can correct them. Most likely you already know what they are in ambulatory care, so check your list against the ones that these organizations identified. Prescription management, new patient appointments, check-in, check-out, messaging, which delivers the internal communications, lab orders and reports, data gathering and reporting, and physician referrals. Just as in disease management, if we can identify the problem, we can find a way to correct it. To evaluate a workflow, bring together a small group that represents one person from each department involved in each workflow. You'll need one person in each workflow study to be the facilitator and another person to be the scribe. The facilitator's job is to ask two simple questions. What do you do? And how did this piece of information get here? The scribe's job is to create a diagram that maps out the work as it described and connects the work with arrows, sort of a critical path analysis. The work group has reconvened, so let's take a look at how they're working through their lab order and results posting workflows.
In my hand, I have CBC results for a patient with diabetes that was in the clinic yesterday. How did it get to me? I know you handed it to me, so let's start there. What do you do?
Well, I found the file on your desk. Maybe you should start with the nurse?
You examined the patient, then asked me to order a blood test. So I wrote it down on this sticky note, put it on the file, and sent the patient to the lab.
What happened next? Can we get someone from lab in here?
It was a routine blood draw. I took the label with the patient's name and wrapped it around the tube and put it in the spinner.
There's something missing. How did the patient's file number and lab number get on this report?
We have to look up each patient's name in our billing system, and then we write the chart number on the label, because our lab system tracks patients by both chart number and lab test.
How did the lab test number get onto this CBC report?
Our in-house lab system creates a new number for each lab test. It's so that we can enter it into the system flow sheets.
Wait, we have electronic flow sheets?
Well, in the lab we do. I can print out results for a single test, or I can compare results from a history of tests and create a trend line.
Have I ever seen these?
You have. But you asked us to transfer the lab results onto the patient's flow sheet. See, here's where I've transferred the lab result in black ink. If the result is out of range, I write it in red.
How do you have time to transfer these lab results? Isn't that something our MAs are supposed to do?
For a while they did, but the lab director saw that they were making too many errors in transferring the results. See, here's the lab result, and then here's the paper record. The order of items on each list doesn't line up. It was too easy making a mistake transferring the numbers.
Why didn't we change the order?
That's the way they come from the lab.
I was just following your orders as to how you wanted things in the charts.
Are you getting all this?
No problem.
Okay, so you transfer these numbers onto a paper chart, and then what do you do?
I clip the file onto the top of the patient's file, and I put the file on your desk for your review.
And then what happens?
Well, then you page me and ask for the patient's results, which means I begin a search for the medical record. I look at the patient's name in the scheduler to get an idea of when she was in last and who saw her. And then I backtrack and search for the file. It's usually on your desk.
Okay. And then what happens?
You review the results and hand the chart to me. I then take the report and the chart and file it back with previous results.
Do you file in chronological order?
We try.
You know, I don't recall ever seeing these results. Do you know if we even got reimbursed for this?
I double-check the encounter form before the patient checks out so we can submit the lab test to billing. We'll need it again later when we generate the UDS reports. But sometimes the patient walks out with the encounter form and then we have to recreate the entire visit.
Yeah, I've spent too many hours recreating those. The EHR will solve that problem. That diagram's a mess. We can do this better in an EHR.